one more question before let me go to Dr. Sangamitra. So, Sangamitra, when you come to the ICU, sometimes it does happen that you have sugars that are 200, and then suddenly in the afternoon the sugars become 80 and 90. So, as a dietitian, does the doctor call you up, or what changes do you do? So, for example, you've set a diet in the morning. Essentially, in my hospital, and I think probably this might be the way it may be, in the morning, the dietitians would come, take a round with us, and then set up the diet. And when they set up the diet is there for the whole day. And now in the morning, the sugars were, say, 120, 130. In the afternoon, it becomes 200, and the evening becomes 40. Do the surgeons or doctors call you up? And after that, is there a change that you do in these particular situations? Dr. Sangamitra.
Not
Okay, we lost her, and as soon as Sangamitra comes back onto the screen, I will stop and we let her talk. But can I make a couple of suggestions here?
Yes, sir. Yes, sir.
Yeah. So, no, I think she may have to log in back again. Her screen is locked.
Correct.
Okay,
so it's okay. Let her get back to that. Meanwhile, what I'll do is I'll go back to Sir again.
So can I just make a comment on that? Now,
sure.
Glucose control. How do you know what the glucose level is? That has been a big problem. You keep on finger sticks may not always be reliable. And then the corporate hospitals also, a simple finger stick that may cost around 15 rupees or something. Many corporate hospitals actually charge 300 rupees for a glucose level. Okay,
correct.
350 rupees. It is simply not cost effective. So there have been a lot of studies, the use of continuous glucose monitoring, like I have here. Okay, to share some information with you. The use of continuous glucose monitoring in an ICU is problematic. I agree with you, Sanjit, but it's a great area of study. Now, remember also that when you have our dietitians give a diet to a patient and the patient is consuming something orally, maybe supplemented with a diabetic specific formula, it does not matter what the 1 hour glucose is. It may even be 230, 240. It may be, but then you have to look at the 2 hour glucose. So there's no reason for us to panic in 2 hours. However, if the 1 hour glucose is very high, 200, 260, then they may need supplemental insulin to cover that hyperglycemia, the postprandial hyperglycemia. But major changes are really not needed for the glucose after 1 hour. This we'll understand only when you have the continuous glucose monitoring. And we have to educate patients also in the outpatient. Don't panic just because it goes up to 220, 230 or something. Over.
Yeah, I just got disconnected. I couldn't answer your question.
Yes, please,
so when we are doing the routine rounds for hypoglycemia, first of all, we need to find out whether the patients have been fed properly or not, because there can have been interruptions in feeding because of some tests, or the nurse has forgotten, or the patient has refused. So that is the first thing. If patients are on an oral diet and they typically are supposed to be having some ONS in between, we need to find out whether that has been skipped or not. Now, this is particularly true for patients who have renal and hepatic impairment. I find that these patients are the ones who suddenly go into hypoglycemia because the gap has been too much, and probably because the ONS was not given, or the SIP feed which we had planned in between was not given to the patient. Regarding hyperglycemia, apart from planning the diet, the carbohydrate, the macronutrient, the protein and everything, there are sometimes hidden sources of calories which we tend to miss out. Like for instance, propofol, it's got calories, right? Patients who are on continuous RRT, they sometimes use, nowadays it's a common practice to use citrate. So those are sources of hidden calories. So when we are planning the diet and the patient is persistently having hyperglycemia or fluctuations, these are some of the things I think which clinical dietitians need to look into. That apart from the diet that we have planned, is it being delivered properly? Whether some hidden sources of calories are there, or some underlying metabolic condition is there. also take the initiative and follow up. Even if the doctors don't alert us or the nurses don't tell us, we need to check the blood sugars and follow up on this.
Correct, correct. So, Dr. Sriram, I was so excited to see that CGM on your on your hand, and I think we are at this moment in the middle of a data study that we're doing on CGM in intensive care unit, and it's a beautiful device. It's a beautiful device. But
That's
coming
the
to
future.
CGM. Yeah, yeah. So, but coming to CGM, we are in the situation where artificial intelligence, machine learning, and things like that are coming very, very big in hospital environments and intensive care everywhere. In fact, I recently had the privilege of having looked at the Medtronic Guardian Connect system, which is a AI-based device which actually talks to the CGM. It actually talks to the CGM, and it's got it actually gives you a feedback of everything that you need to do. It's called the Insight app. It's also got a food logging. What happens is, well, the moment you feed the person, you log it on that, and then it learns from backwards. As to what happens to you when you take a particular diet or a particular food source. It's a beautiful app per se. Do you think things like this, where continuous glucose monitoring on the background with deep learning, machine learning, artificial intelligence, and when you actually feed them back with data, it will help us better to alter our nutrition on a day-to-day basis? Do you think in an hour-to-hour basis is thinking too much? But if you were to think on a day-to-day basis, would it do anything for a day-to-day basis? For example, let me take the example of you on a CGM, and we've learned from your CGM, the AI has learned from your CGM that your when you eat an idli, it actually goes up and comes down. For that matter, you take a formula feed, and that's what happens to your spikes of your sugar. Do you think that this is going to be the future, where CGM and AI would actually tell us what we should be giving to our patients the next day? Is it going to be that way?
Yeah. So in terms of intensive care unit, we don't know as yet, mainly because the CGM, the continuous glucose monitoring, picks up the interstitial glucose levels, and it does not pick up the blood glucose, and there is a lag period. So we don't know about intensive care unit. However, in the outpatient setting, including prehabilitation of diabetic patients before an elective operation, the CGM is really absolutely beneficial. And the reason is textbook information does not work. For example, I have found that personally, some diabetic specific formulas don't even tickle my glucose levels. It's the same. Nothing happens. There are other so-called products that it goes sky high. I don't know the reason. It actually depends upon your gut microbiome. At the last Aspen meeting, Gail Kreshe, the president of Aspen earlier, who's been to India several times, Dr. Kreshe presented a paper to clearly show that it depends upon the gut microbiome. For some people, white bread actually doesn't do anything to the blood sugar, but brown bread increases the blood glucose, contrary to what we are taught. So it is extremely important that the CGM is used for educating the dietitian and the patient. But as I'm told repeatedly, you don't want to develop diabetic neurosis by having the CGM all the time. It is only for you to learn what your body is, and then you can stop it. However, the topic for discussion today is actually glucose monitoring in the critically ill patients, so I'm not going to dwell too much more on the benefits of CGM in an outpatient. Suffice it to say, it is extremely useful. It brings in discipline. You are muted, Sanjit.
So I understand that we are in a situation where CGM has not really come into commonplace in intensive care unit, but I fathom that there is going to be a time where we will probably our AI will learn what we are supposed to feed. In fact, this is what is going to happen. It's already done in a couple of fields, and I think the future is going to be artificial intelligence and deep learning, which will help us.